about, right? So when mom comes in, we're gonna get that prenatal history. So looking at her GTPAL, looking at her medical history, doing a head to toe, checking mom's age, the gestational age of the baby, thinking about labs that may need to be completed. Again, remember your first stage of labor, again, we're getting dilated, we're getting a face during that time period. Now, moms can have two different ways that their membranes can rupture. And if you remember in the lab day that we had, you saw a spontaneous and an artificial, right? So like it says here, only about 0.25% of women actually have a spontaneous rupture. So that means they say, oh my gosh, my water broke, right? And sometimes they come in and they don't know if it's their water breaking or if it's just extra discharge. So they'll come in and we'll do a test. We can do two things. We can take the fluid and look at it under a microscope, and it would have this burning pattern if you look under a microscope. Also, you can test the pH level. So either way of that can tell you if it's truly amniotic fluid or not just extra fluid of some kind. Now we can also break the membranes artificially. So we take that little plastic hook and rupture the sac. Again, remember the acronym TACO. So do you remember what that stood for when we talked about it before? Time. So what time did the membranes rupture? Because again, we don't want them ruptured from, well, sometimes they are for over 24 hours, but again, greater risk of infection then. What else? What does the A stand for? Amount. So again, our average amount is about 1 liter, right? So if they have too little or too much, again, remember we talked about kidney issues or GI issues. What else? Color. So again, we want it to be what color? Clear. Yeah, clear. We don't want green fluid. Again, it could tell us the baby had its first in utero stool. And then odor. Again, looking for infection. All right. So they're going to come in, get a fetal heart rate. Again, if mom's coming in with contractions, a fun way to kind of see if they're mild, moderate, or severe. So again, if you touch the tip of your nose, how that feels, that's how mom's belly would feel during a mild contraction. If you touch your chin, that's how it would feel during a strong or moderate contraction, and then your forehead, that's how it would feel during a strong contraction. So again, when they come in, even just placing hands on their belly, you can feel a difference. We're going to continually assess them. We limit our vaginal exams because we don't want to introduce bacteria. So we'll not check them frequently, even though they want to be checked. And then again, they may need to have a Leopold maneuver done if the baby is breech, but we'll talk more about that later. All right, so this is just a belly or a picture kind of showing mom's belly nice and relaxed, and then during the contraction, it can tighten up and raise. Again, as you're watching on the monitor, you'll see it's coming up and then it comes down. They have a period of relaxation and then the next contraction again. When you palpate again or check the cervix, again, in this first picture you see what would be an undilated, uneffaced cervix. Again, you can see just able to barely have one finger enter, and then again, when they start to dilate, you can start to palpate again that sagittal suture line. They'll come in and have labs, looking at their urine, getting a CBC. Again, if they don't have any STI results, we'll get those just to see what we're dealing with. Again, as we're assessing them, we're going to only do vaginal exams when needed, watching for complications, monitoring that fetal heart rate. Patients can change positions throughout their labor. In fact, we want to encourage them to have frequent position changes. It actually helps them with their strength and getting through there. Have them rest between contractions, right? That's important. They have to save that energy up in order to have that baby and be able to have good, strong pushes. In our second stage, again, this is going to end when that baby is born. So when we're going through We want them, again, resting between contractions. They can only have clears and ice chips during labor. I know they sneak stuff all the time too, but we want that just in case if we needed to do anything else that we don't want risk of aspiration to. And then, again, sometimes they may have that prolonged stage that may result in a C-section. Again, when they're pushing, we don't recommend that they hold their breath. You always see in the movies they'll go, like, you know, like super, like holding their breath and pushing down. But again, that can trigger the Valsalva maneuver and actually decrease fetal perfusion, so we don't encourage that. We want a nice cleansing breath and help to support them during that time monitoring the baby. As the baby crowns, again, sometimes you'll see they have like their hands there to help guide the head out, also to guard that perineum. Some doctors you'll see will pour some mineral oil or different things to try to help with that delivery. But again, when we have, some have hands off, so again, they just want the body to expel the baby naturally. And then we always want to check for nuchal cord, so again, that number of times that the cord is wrapped around the baby's neck. We also want to check and see you know, if we suspect meconium at all. Even as the baby's delivering, they may have that happen during delivery, so again, we want to have that suction and laryngeal available. So with Ripken, the hands are on to protect the perineum and guide the baby out. So it says they draw it down and apply pressure to the coccygeal region to allow the forces to expel. When the baby's born, again, we'll get Apgars. So again, done at 1 minute and 5 minutes of life. We're going to keep the baby warm under the radiant warmer. If they don't immediately go to skin to skin, make sure they have a patent airway. We may need to suction. And again, what do you suction first? Mouth before nose. Again, looking at the Apgar scoring system, looking at activity pulse, grimace appearance, and respiration. Again, scoring accordingly based on how they look. Now, tears can happen. Back in the 90s and late 80s, they used to do a lot of episiotomies where they would cut to try to, what they were trying to do was to avoid tears or avoid having the tears be worse than they should be. But what they found was when they did the episiotomies, they actually tore more. So you'll see now they don't do as many episiotomies as they used to. But a first degree tear would be just the skin and structure superficial to the muscles. A second degree will actually go through the muscles of the perineum. A third will go all the way to the anal sphincter, and then the fourth will actually involve the anterior rectal wall. So for those of you that are in postpartum and see that your mom's had 4th degree tears, again, they will be in a lot of pain. They also may need, for 3rd or 4th degree, they may need to be taking Colace, again, ice after to try to help with swelling and pain. All right, and then in our 3rd stage, again, we get this gush of blood, and then here comes the placenta again. Sometimes moms will say they feel like it was, like a fullness, and then all of a sudden relief. So then we have that. This is a picture, again, of the 2 sides of the placenta. The shiny Schultz side that you see in that top picture, that's the fetal side of the placenta, and then the dirty Duncan, or this bottom picture, was the maternal side of the placenta. Afterward, we want to watch for signs of postpartum hemorrhage. If moms want to have cord blood taken, we would do so at that time. And again, apply ice to the perineum, repair any lacerations. In that 4th stage of postpartum, again, it's okay to have baby skin to skin. In fact, we encourage that. Bleeding may be heavy at that time period. Again, they can have some clots, but again, nothing bigger than a golf ball. And we're going to be measuring the fundus and doing fundal checks. So now let's move on. Sometimes we don't get obviously through all these slides because there's a lot of labor and birth complications, but we'll pick them up next week if we don't. All right, so labor and birth complications. We can have a baby. Obviously that's preterm labor, and you remember those times there. Again, it could be spontaneous, unintentional, unplanned. Sometimes it's medically indicated. Again, we try to keep the baby in as long as we can, but if either baby or mom's not safe, we have to have it. Having an elective preterm delivery is not recommended, nor is it usually done by most providers because of possible complications. When we have our babies, some risk factors for spontaneous preterm birth, if they've had a previous preemie, that puts them in that bucket. If they have genital tract infections, if they've had multifetal gestations, if they've had a low pre-pregnancy weight, some socioeconomic disadvantages, infections, hypertension, smoking or drug usage. The World Health Organization estimates about 10% of births will be preterm, so about 13 million babies are born each year. And then about 12% are what they call the late preterm, so like a 34 to 36 week. We talk about them in another lecture. But they're seeing some decrease due to improved fertility and limiting of delivering the babies early. Again, when we think about preterm birth, it's obviously a leading cause of neonatal mortality, and 70% of neonatal deaths are due to that preterm birth. They can have long-term neurological impairments. They can have CP, hearing and vision impairment, chronic lung disease. They say on average it costs $26.2 billion in the US, or about $51,000 per premature infant. So again, we want to make sure that, try to keep them in as long as you can. So we can use something to help us. So the tocolytics, if you remember the phrase, it's not my time. So the INMT stand for the drugs that you can give to try to arrest labor. None of these are approved by the FDA, but again, we try to use them to prevent the labor from occurring. So again, that relaxation occurs so that the contractions would hopefully arrest. If the baby is at risk for delivering early, again, we want to give them some steroids to mature their lungs. So the betamethasone we can give them to try to stimulate that fetal lung maturity. It promotes the release of an enzyme to produce surfactant. It can be painful. We've given it IM to our moms at Barberton before. If they are diabetic, check their blood sugar because it can affect their blood sugar as well. So again, once the labor dilation goes to like 4 centimeters, they're probably going to have the baby. Okay, they can't arrest that labor any longer, so we got to make sure that we try to get ready for that delivery. Now, premature rupture of membranes, or sometimes you'll see it listed as a PROM on the mom's records. So again, that's the rupture of the amniotic sac or the leaking of the fluid before the onset of labor. So again, the cause is unknown. Infection is a risk over 24 hours. Neonatal sepsis is a risk, and likely that they'll have labor become induced. Usually they birth within a week. They try to hold them as much as they can, but and then they can have a pre-premature or a PPROM. Again, a lot of times if they have like an infection of the uterus, or if they have STIs, then they can have this. They can also get bacterial infections in the uterine cavity. So again, things like fever in the mom, tachycardia in both mom or baby, a foul smell or discharge, an elevated white blood count, again, can be a cause of complication for birth. Again, with babies, you see it on the screen here what can So again, that's why we're limiting our vaginal exams, because we don't want to have any kind of infection. If they are suspected of it, intrapartum, they will receive antibiotics, usually like Ampergent, some antipyretics and fluids. And then we got our overcooked turkeys. So again, a pregnancy beyond 42 weeks. Some docs will induce at 41. It's still kind of controversial how they'll wait. Some will just allow the pregnancy to continue. But again, these babies have risks as well, if for just as much for being overterm than they would for being on time. So they can start to lose that amniotic fluid. It can lead to compression of the cord and fetal hypoxia. The placenta starts to wear out. It's old. It's beyond its useful life. The baby starts to use its glycemic stores. So the baby's at risk for hypoglycemia at birth. Again, if they're a post-term baby. They're at risk for becoming macrosomic, or that large for gestational age, which can make it hard to deliver them, right? So if they have a 12-pound baby, it might be a lot harder to push out, which could lead more to either fetal distress or even the need for a C-section. They also are at a higher risk for MEC aspirate because they're later in the term, they could have had their first stool. And then they can get really dry, cracked skin. They don't have that vernix on them anymore to help them through that. So we'll do a Ballard on our babies when they're born. When we look at our moms, hypertonic, so again, painful, frequent contractions. A lot of times this is with our first-time mothers. We want to try to promote relaxation, a warm bath, a quiet environment, hydration. And then sometimes we can have hypotonic, so again, they're ineffective, and sometimes that can lead to the need for either augmentation of labor or even cesarean. The word dystocia, long, difficult, or abnormally slow labor. So again, a lot of times this is when moms fail to progress. So they may have ineffective contractions that causes them to not be able to expel the baby. Maybe the baby is stuck or not in the right position. Increased risk for uterine dystocia would be someone who's overweight or short stature, advanced maternal age, someone who has uterine abnormalities, breech baby, cephalopelvic disproportion, so you'll see CPD written, and basically what that means is the baby's too large to fit through the pelvis, right? So you can't fit it through if it won't fit, right? Sometimes the uterus gets overstimulated, right? We give oxytocin, pitocin to start labor, but sometimes it gets too much and it's overstimulated and then it doesn't want to help. And then sometimes if the anesthesia is given too early, like if they get their epidural too soon, it can slow down their labor as well. On the other end, we have precipitous labor. So we had one of these at Barberton. The mom came in, I want to say it was within 20 minutes she delivered the baby. She had said her previous pregnancy was like 30 minutes. So it was like you barely get her in with an IV and then all of a sudden the baby's being born, right? So that's labor that lasts less than 3 hours. Only about 2% of the population has this happen, but a lot of times you'll see moms that had it in the past will have it again. Babies that are in breech presentation may need to have a version done. So this is where they'll externally first try to move the baby from a breech to a head first position. The version is scheduled after 37 weeks, and it's also, they'll have an ultrasound done before. So we had one time in Barberton, they came in for the version, and they went to do the ultrasound to verify the baby was still breech. Obviously, you don't want to try to do a version, the baby's not breech anymore. But they go to do the ultrasound, and then they found something wrong with the baby's bowel. So then they canceled the version and sent them to maternal fetal medicine, and then came back into the section like the next week. But so you have to look at that. Again, It has obviously an increased risk of C-section, right? And one time I said to the nurse, like, what happens if the version's not successful? And she's like, well, that's why we have a cesarean room ready to go, right? So again, you have about they say it's about a 50-50 success rate with actually turning the baby manually. The doc that was at Barberton, the nurses there told me that he had about an 80-20. So he got about 80% of his versions turned.
Are there any fetal risks with the versions? Or?
No, sometimes it can like stress them out, or if they can't get them to, turn, it just results in having them delivered by C-section. But if the baby gets stressed, you could have some deceleration and things like that. But there's no harm done to the baby by trying to. It's not comfortable, right? But it doesn't hurt them. All right, induction of labor. So sometimes, again, elective. Again, probably 20 years ago, you had, moms that would come in and say, I want my baby born on this day, and they would come in and electively have their induction done. They've tried to limit that now, but again, we can do it either chemically or mechanically when we look at it. When we use something called a Bishop score, so a Bishop score greater than 8, you have more chance for successful induction. So it looks at dilation, effacement, station, consistency, and position. So again, you can see the little sample of that there. You also have improved outcomes when it's at least 39 weeks that you induce the labor as well. About 50% of inductions are not medically needed. So again, sometimes it's not warranted. But again, we can do things medically for like post-term, come in and induce the labor. If mom has obviously preeclampsia, pre-rupture of membranes, or if there's any kind of fetal compromise. So when we look at ways that we can do this, again, cervical ripening method, you can see here, they can strip the membranes, they can insert a balloon catheter. That catheter dilates and causes endogenous prostaglandin release. But unfortunately, there's an increased risk for infection with that. You can also, again, with oxytocin, again, to stimulate those uterine contractions, but again, we want to be cautious when we use that. If the fetus is not engaged, or if there's any type of active infection, you never want to perform an amniotomy. You'll always monitor the fetal heart rate before and after, right? So if you're going to break that water, you're checking to make sure the baby's stable before you do so. The water breaks, you're checking your taco, and you're checking the baby's fetal heart rate after as well. And again, depending on the situation, it may need to escalate to other interventions. All right, we're going to stop here with augmentation, and we'll pick it up next week.